So friends, today my talk deliberation is on pregnancy after ART. Is it different? We all know now ART accounts for 1.6% of all infants and 18.3% of all multiple birth infants in the United States. And why I am projecting the statistics of United States? Because in India, we don't publish our results, we don't publish our reports. So as of now, we don't have exact Indian data as far as these ART pregnancy statistics are concerned. Although most of these pregnancies are uncomplicated, IVF is associated with several adverse maternal and perinatal outcomes. And why are these ART pregnancies at higher risk? As Dr. Madhumati was already saying, that these may be at higher risk, maybe because of increased maternal age, pre-existing comorbidities, cause of subfertility itself, drugs used to treat her subfertility. She has undergone some surgeries, so maybe that can be the outcome of previous surgeries, or very rarely the IVF procedure itself. So ART pregnancy, friends, is like kabhi kushi, kabhi gum. On one hand, it elevates the burden of subfertility on the individual and families, but these also present certain challenges in the form of higher rates of multiple delivery, preterm delivery, and low birth weight delivery. So, can we say that ART pregnancies are different? Yes, they are different mainly because of two reasons. That is multiple pregnancy, but friends, these pregnancies can be at high risk regardless of multiple gestation as well. So look at this study which was published in 2017 on the obstetric complications. The increased risk of obstetric complications from ART appears to apply to not only twin gestation but as well as singleton pregnancies as well, in the form of increased risk of preterm birth and congenital malformations. So just I will be enumerating the risk for the mother and for the fetus. So when we are talking of maternal risk in ART pregnancies, it starts from the first trimester, that chances of miscarriage or ectopic pregnancy is higher. It is 15% if she's less than 35 years, 25% if she's 35 to 40 years of age, and it is 35% if she is more than 42 years of age. If she is having multiple gestation, then we all know that this pregnancy is more prone for abortions, gestational hypertension, placental abruption, and placenta previa. ART pregnancies also carry increased rate of obstetric interventions in the form of induction of labor and elective C-section delivery. And yes, there is certain amount of psychosocial impact, especially in ART pregnancies as compared to the naturally conceived pregnancies. Now, what are the fetal risks in these ART pregnancies? There are two, the chromosomal and the multiple births. Chromosomal risk, the de novo chromosomal abnormalities in IVF ICSI babies can occur, especially if it is a male factor subfertility. And if the female age is higher, then of course the aneuploidies in pregnancies adapted for maternal age and number of fetuses. Multiple births, then these babies are more prone for prematurity, low birth weight, and increased chances of neonatal morbidity and mortality. So now what is the best way to protect the mother's health and health of the baby? Regardless of how the pregnancy has occurred, you all will agree with me that is good antenatal surveillance. Why antenatal surveillance? Because by doing good antenatal surveillance, we can triage our mothers into high risk and low risk pregnancy. I know any low risk pregnancy can become a high risk pregnancy at any given point of time. Second advantage of antenatal surveillance is you can screen the fetus for chromosomal errors, structural defects, and growth abnormalities. The third point is prediction and prevention of maternal complications. And of course, if you are doing a good antenatal surveillance, you can decide the time and the mode for safe delivery. Now, when we are talking so much about antenatal care, do we have a standard protocol? The answer is no. No, it starts with continuation of progesterone support because many of our IVF patients, they come from periphery, they come from other cities, they get embryo transfer done at our place and then they go back to their native place. So when they go back to their native place, they connect with their local OBGYN. So when they are coming to you have to see what prescription she is carrying from the IVF center. And the first and foremost is progesterone prescription by each and every center. You have to continue that progesterone in the same dose. How long to continue? It is individualized for every patient profile, but usually we continue it for 12 to 14 weeks of pregnancy. You have to continue the folic acid supplementation, continue the thyroid medication if she is on any, or to make your life easy, please continue with all the medications prescribed by ART consultant till you get a beta SCG report. Yes, when you get beta SCG report and she turns out to be positive, if you want to order certain extra test, please go ahead and order some blood test. But don't rely only on one beta HCG titer. You have to see for the rising HCG titers. Case-specific blood test, I already said, you can go ahead. And hemoglobinopathy screening, usually in Vidarbha belt, we do. But if you feel that it has not been done and you want to do it, you can go ahead and do hemoglobinopathy screening for these women. Now coming to the OHSS, that is ovarian hyperstimulation syndrome. As I said, they get embryo transfer done at our place and then go back to their native village. So everyone should know the pattern of OHSS and its management. Early OHSS, it usually presents 3 to 7 days after we give trigger. After giving trigger, after 2 days, we do pickup. Then nowadays, if we are doing blastocyst transfer, it is done on day 5. So usually you don't encounter early OHSS. But late OHSS, yes, it presents 12 to 7 days or 12 to 17 days after SCG. That is 10 to 12 days after our embryo transfer. And this late OHSS is induced by endogenous SCG from the trophoblast of the implanting pregnancy. So everyone should be very well versed with the management principles of these OHSS, that is monitoring, supportive therapy. You have to maintain the intravascular volume. You have to prevent the complications, and if it has already developed, you have to treat the complications, and you have to counsel, counsel, and counsel. This is in nutshell, I am telling you the outpatient care and inpatient care for OHSS. Outpatient care is very simple. You just have to tell her to limit her physical activities, do her weight daily, monitor intake output, do daily follow-up, and she has to report if symptoms worsens or she gains weight of 2 pounds, that is 1.2 kg, 2 pounds per day. If the symptoms worsens, then you have to admit her and then you have to monitor her intensely with her vitals, with her intake output, daily weight, hematocrit, serum electrolytes, LFT, coagulation profile, and if it is uncontrolled, you have to shift her to ICU and look for renal failure, ARDS, and DIC. So don't take OHSS very casually. Mild to moderate OHSS, you can manage. You all should know who are at risk of OHSS. If she is a young woman, if she has conceived and she is a known case of PCOS, she is having low BMI, then she is at more risk of OHSS. Of course, prevention is better than cure. Now, all IVF centers in cases of PCOS, they are doing stimulation by antagonist giving agonist trigger and doing freeze all embryo cycles. So practically speaking, we all are OHSS free clinic. But this is about IVF. You can have OHSS even in IUI pregnancies, even with clomiphene, letrozole, though the incidence is very rare. And if IUI is done with gonadotrophin stimulation, you have to be alert and you should be suspicious of OHSS. Now you have documented the rising titers, there is no OHSS, and now she has become 6 to 8 weeks pregnant. I'm sure you all will agree with me that this is the paradigm shift as far as the antenatal care is concerned. Previously, we used to do intense monitoring and surveillance in the third trimester, but now it is the reverse. We have to do intense monitoring and surveillance in the first trimester, as some very important complications that may occur later in pregnancy can be predicted in the first trimester itself. So the inverted pyramid helps in dividing cases into high risk and low risk in the first trimester. Now, either she is with you from the beginning, that is after the embryo transfer, or she has come to you after testing her UPT at home. She is positive. Now she is 6 to 7 weeks of pregnancy. Remember, ultrasound should be done for all ART pregnancies at 6 to 7 weeks of gestation. Why? You want to see the exact dating of pregnancy. We want to document whether it's an ectopic pregnancy, intrauterine pregnancy, or a heterotropic pregnancy, whether it's a missed abortion, whether it is a single, multiple pregnancy, and if it is a multiple, what is the chorionicity. So that is why it is must to do the scan at 6 to 7 weeks of pregnancy. Following ART, the risk of miscarriage may seem a bit higher than in spontaneous pregnancies, but this can be due to earlier pregnancy detection on one hand and the advanced maternal age on the other hand. The major complication of IVF is the risk of multiple births. I know it is directly related to transferring multiple embryos at the time of embryo transfer. So can it be prevented? Yes, if we all opt for elective single embryo transfer. But remember, even if we have done single embryo transfer, spontaneous splitting of embryos can occur, though this is rare. But if this splitting occurs, it will lead to identical twins. What about vanishing twins? In IVF, remember, twins are more often conceived than born. Most twins, they vanish in due course of time. We don't have the true incidence of vanishing twins, but according to one data, around 30% of these twins will ultimately result in singletons and less than 10% will end in complete abortion. If she is having multiple pregnancy, the aim of our antenatal care is, of course, the prolongation of gestational age to have the increased fetal weight, improve the perinatal morbidity, mortality, and decrease the incidence of maternal complications. So here it has to be a consultant-led team. You just can't allocate these pregnancies to your juniors or resident doctors. Embryo reduction, if it is triplets and more. We don't do embryo reduction if it is a twins. If she is eligible for embryo reduction, it is done after 11 weeks of gestation. Don't forget to manage her with your routine antenatal care, and you have to assess the cervical length and the competency of the cervix and do careful watch for the complications. You have to look for hyperemesis gravidarum, and as I said, inverted pyramid will pick up most of these complications in the first trimester itself. How to monitor if there is a single twin demise, or if she gets fetal reduction done and she comes to you for further monitoring, or you are seeing a case of triplets and you are sending her for fetal reduction. You have to do baseline coagulation profile, counsel her regarding prognosis of the second twin. Early delivery is not warranted as preterm delivery may harm the surviving twin. And remember, cesarean section is not indicated in these cases. Even if it is a multiple birth, gestation, but this is an ART pregnancy. So these ART pregnancy twins, they have very good outcome because they are monitored very well. Parents are motivated and doctors also pay extra attention to these pregnancies. Now I am quoting some literature which are the common asked questions as far as ART pregnancies are concerned. What about the risk of congenital malformations? There are various studies. The meta-analysis demonstrate the association between IVF, ICSI and congenital malformations, although it remains unclear if this association is due to infertility or factors associated with the procedure or both. It is also difficult to distinguish the risk associated with IVF alone versus IVF with ICSI. So the Society of Fetal Medicine, V means the Society of Fetal Medicine recommends a detailed obstetrical ultrasound examination. It should be performed for pregnancies which are achieved with IVF and ICSI. What about the risk of congenital heart disease? Several studies have reported higher rates of total congenital heart disease in the IVF ICSI pregnancies compared with naturally occurring pregnancies. And hence, the Society of Fetal Medicine recommends fetal echocardiography should be offered to all these pregnancies, and we are routinely doing fetal echo at 22 weeks of gestation. Now she has successfully crossed and now she is 11 to 13 weeks of pregnancy. We all know that this is the time to do nuchal translucency scan, the scan for soft tissue markers and the double marker. Now everyone should know if this is an ART pregnancy and you are sending double marker, please ask her whether this is the IVF cycle by her own eggs or whether donor eggs have been used. When you are asking this history, don't ask in an open because this is a very, very confidential information. Even if she's 30 years of age, don't assume that this is a pregnancy by her own eggs. She might be a case of premature ovarian insufficiency. So it is better to ask whether it is self-egg or donor egg cycle. And in case it is a donor egg cycle, then when you are filling the form for double marker, you have to write the age of the donor and not of the recipient. So this is a very, very important point at 11 to 13 weeks of pregnancy. Of course, you will be looking for the vanishing twins. This is the time when we take decision whether she needs embryo reduction or not. Cervical length should be measured. Post speculum examination should be done. In case of any doubt, you can do NIPT. In first trimester itself, you all can predict the chances of gestational diabetes, preeclampsia, preterm labor, placenta previa, and you have to look for asymptomatic bacteriuria and chlamydial infection. What about the cervical length assessment? Asymptomatic single pregnancy where cervical length is less than 25 millimeter, you have to, we don't do routine cervical cerclage even if this is an ART pregnancy, even if she is having twins and having ART pregnancy, routine cervical cerclage is not recommended. Now, either she is continuing with you or she has come to you when she is 18 to 20 weeks of gestation. Now, this is the time to do a detailed anomaly scan for structural abnormalities. This is the time to do quadruple marker if double marker has not already been not done. If you are sending quadruple marker, again you have to ask whether it is a self-X cycle or a donor X cycle. And if it is a donor X cycle, you have to mention the age of the donor on the form and not the age of the recipient. Here also, again look for the cervical length, do post speculum examination. In case of any doubt discrepancy, you can go ahead with NIPT or amniocentesis. And as I already said, in all ART pregnancies, we recommend fetal echo at 22 weeks of gestation. Now, what is the risk of PIH in this ART pregnancy? I am showing you the study published in British Journal in 2015. This was a cohort study of over 5 lakh women, which was done to determine the risk of preeclampsia in these ART pregnancies. And after adjusting for maternal age, interbirth interval, and the presence of new partner, women undergoing ART, they had a small increase in odds of preeclampsia. So this should be known to each and everyone. And is PIH more in self-egg cycle versus donor egg cycle? You all can see what the statistics and the research is saying. Pregnancies which are achieved with donor egg cycle, they have more than double the risk of preeclampsia when compared with other methods of ART, that is ART by her own eggs, and more than fourfold increased risk compared with natural pregnancy. So this is the importance of asking her whether this ART pregnancy is by self-egg or donor egg cycle. Now when we are talking of PIH, can you just give routine aspirin and prevent this? Look at again the statistics. The Society of Fetal Medicine, they do not recommend low dose aspirin in those patients with IVF pregnancy as the sole indication for preeclampsia prophylaxis. You all know, just now I only told you that it is chances of PIH are higher, but just for this PIH prophylaxis, you can't prescribe aspirin. However, you can prescribe if one or more additional risk factors are present, then you are justified in prescribing low dose aspirin. What about PPROM? Two systematic reviews and meta-analysis have shown that the probability of PPROM is significantly increased after ART pregnancies compared to spontaneous conceptions, both in singletons and multiple pregnancies. Now, what about the risk of preterm birth? A meta-analysis of singleton pregnancies have demonstrated that IVF is associated with higher odds of preterm delivery, low birth weight, and very low birth weight compared with the naturally occurring pregnancies. In addition, the progesterone supplementation, which is initiated for IVF cycles, is not indicated after 12 weeks of gestation if it was solely initiated for IVF purpose without any indication. So how long to continue progesterone support? You have got the answer, that is up to 12 weeks of pregnancy. Now, what is the prevalence of fetal growth restriction, whether it is higher in IVF pregnancies? An increased risk of small for gestational age infants is documented for singleton IVF pregnancies. Meta-analyses have described a higher risk of SGA babies in IVF ICSI pregnancies from fresh cycle compared with frozen cycle. So another term which routine OBGYN should get well versed is whether this is a cycle by fresh embryo transfer or by frozen embryo transfer. Society of Fetal Medicine suggests an assessment of fetal growth in the third trimester for all IVF pregnancies. However, serial growth ultrasounds are not recommended for the sole indication that this is an IVF pregnancy. So this was all about first trimester, second trimester. Now she has come to you in third trimester, or now she has entered her third trimester. So what should be done in third trimester? Close monitoring of fetal growth, close monitoring for preterm labor, and you have to pay special attention to the placenta, whether it's the placenta previa or adherent placenta. Why? Because IVF pregnancies are associated with higher risk of abnormal placental shape, placenta previa, marginal or filamentous cord insertion, and placenta accreta spectrum compared with naturally occurring pregnancies. So targeted screening via transvaginal ultrasound should be considered in all IVF pregnancies with filamentous cord insertion, succinturate or bilobed placenta or resolved placenta previa to rule out vasa previa. To cut it short, if it is an ART pregnancy, be extra vigilant as far as the placental location is concerned. You have to see whether it is adherent, it is PVA, or there are some other problems with the placenta. It a meta-analysis of 15 cohort studies which compared ART pregnancies with naturally pregnancies. It has been found that the risk of placenta previa is 3 times more in ART pregnancies as compared to the naturally occurring pregnancies. Fetal care, I know we obstetricians are extra careful if it is an ART pregnancy, you have to do the serial ultrasound monitoring. What should be done in first trimester, second trimester has been already highlighted. In the third trimester, these patients are very apprehensive. But for that matter, for each and every pregnancy, we do advise them fetal kick count. The chances of stillbirth, are they increased in IVF pregnancies? Again, the data is saying that pregnancies which are achieved with IVF, they have 2 to 3-fold increased risk of stillbirth even after controlling for maternal age, parity and multifetal gestation. So given this increased risk of stillbirth, the Society of Fetal Medicine suggests weekly antenatal fetal surveillance beginning at 36 weeks of gestation for these ART pregnancies. There are various methods of fetal surveillance. We all are doing it, but at home, the most reliable method is fetal kick count. Remember the goals of your antepartum fetal surveillance. It is to reduce the risk of stillbirth, which is 2 to 3-fold higher in these pregnancies. So the antepartum fetal surveillance techniques based on assessment of fetal heart rate patterns have been in clinical use for almost 4 decades, and they are used along with real-time ultrasound and umbilical artery Doppler to evaluate the fetal well-being. There are various methods of doing this kick count. You all can download it from Google, and you have to educate the patient, her husband and the family about this kick count. Now you have safely reached 39 weeks. So in pregnancies achieved with IVF, does delivery at 39 weeks reduces the risk of adverse perinatal outcomes? Because we should know when to deliver these ART pregnancies. So it is currently unknown whether elective delivery at 39 weeks reduces the risk of maternal morbidity and it improves perinatal outcome in IVF pregnancies compared with expectant management. So what the Society of Fetal Medicine is recommending, that in the absence of studies, we really don't have specific studies focusing specifically on timing of delivery for ART pregnancies. So that is why it is recommended that shared decision making between patients and healthcare provider should be taken when you want to induce labor at 39 weeks of gestation. Everyone knows how to manage these multiple pregnancies and take the care. Now, this is $1,000,000 question. This is an ART pregnancy. So, whether you should do C-section or you should opt for vaginal delivery. Remember, ART pregnancy per se is not an indication for cesarean section. You have to do it only for obstetric indications. I know better said, I am saying it, but yes, many IVF pregnancies are asking you LSCS on demand. Muhurat LSCS, I have put big question marks. LSCS on demand should not be entertained. You have to justify why you are doing cesarean section on her. And if you feel that elective C-section is justified, then you can entertain these Muhurat things, but tell them to come with these Muhurat timings between your routine OT hours. We tell them if they are coming with their Muhurat timings at 2 a.m., 12 midnight, 3 a.m., then they have to bring that Pandit also along who has taken out these Muhurat so that they know that elective surgery should be done in elective hours and they should not be forcibly made an emergency surgery in the odd hours of the night. Now, what about the perinatal mortality? Yes, it is 4-fold increased because of the obstetric complications, because of the low birth weight, and because of the multiple pregnancy. Now, don't forget the postpartum care. As soon as the baby is delivered, everyone just rushes and rushes to take care of the baby. They are just after the pediatrician. How is the baby? How is the baby? But being an obstetrician, remember that these ART pregnancies are more prone for puerperal psychosis, lactational problems. You have to monitor the comorbidities in them apart from taking a good neonatal care. So your responsibilities don't end as soon as the baby is born. Several severe maternal morbidity is nearly twice as likely in pregnancies conceived with ART as compared with non-ART pregnancies. So this should be kept in mind. So every procedure, friends, it has some inherent risk, including IVF. We have not seen any mother dying just because this pregnancy has been conceived by IVF. But yes, as I already said, because of the comorbidities, because of her increased risk, because of the increased risk of obstetric complications, yes, this mother is at higher risk for increased chances of maternal mortality and morbidity, which should be kept in mind. So what you all have to do? You all have to be very good in counseling, counseling, and counseling. Yes, risks are rare, but they are real and they need to be taken into account when thinking about IVF, using IVF to have a baby. This is for we ART clinicians that when we want to take any patient for IVF, we have to screen them. We have to see that this mother is fit for pregnancy. But many couples, they downplay or even ignore the risk due to their desire to have pregnancies. But we have to counsel them about the worsening of pre-existing medical conditions, about the increased risk of chromosomal abnormalities, risk of multiple pregnancy, risk associated with advanced maternal age, and of course about the psychological impact, especially if fetal reduction has been done, if there is a death of one twin. You have to consider the cost of frequent monitoring. You are calling her for frequent ultrasound monitoring. There is a risk of preterm delivery. It definitely imposes more financial burden on them. And if at all she has to take leave from her job, then she is worried about her job as well. Are there certain medical legal issues? Yes. If you fail to diagnose, if you are doing more tests, if you are doing less tests and you are missing out on some diagnosis, late detection of growth problems. So the list is endless as far as the medical legal issues are concerned. So the key takeaways from my talk is pregnancies achieved by IVF with or without ICSI are at higher risk of obstetrical and neonatal complications than spontaneous pregnancies, and close surveillance during pregnancy should be considered. It remains unclear if these increased risks are attributable to the underlying infertility or to the characteristics of the infertile couple or because of the use of assisted reproductive techniques. Multiple gestation definitely remains a significant risk. So treat each pregnancy as a high-risk pregnancy, have a multidisciplinary approach, and early screening and prediction of potential problems will definitely give you a healthy outcome in the form of healthy mother and healthy baby. Thank you, friends. Thank you so much for your patient hearing.